The midface device consists of two components: the insertion tools, which are designed to facilitate introduction of the fixation platform through a temporal approach, and the endotine midface implant, which consists of a fixation platform and anchoring leash used to elevate and fixate the cheek subdermis during a midface suspension procedure. The fixation platform utilizes Coapt Systems' proprietary multipoint technology, which eliminates cumbersome fixation sutures, distributes tension over a wide area, and due to the 5 points of fixation, provides enhanced tissue-holding strength. The integrated anchoring leash provides a simple and secure method of adjustment of cheek elevation and projection. The endotine midface is made from a common copolymer composed of lactic and glycolic acid, which has an extensive clinical history. The material maintains strength for approximately 4 months and then gradually absorbs over the ensuing 6 to 8 months. By the time the device dissolves, the facial tissues will have formed a stable biological fixation to maintain suspension. The following surgical procedure represents one of several approaches that may be selected by the surgeon to perform a midface suspension with the endotine midface.
If we look at the patient, we can see that we have our malar eminence, but there's been some descent to the malar fat pad and more laxity down in this area. What the procedure will do is it tends to elevate this malar pad, giving some more prominence to malar eminence, but also removing some of the laxity in this lower jowl subbuccal area. This is the local anesthetic that we'll use. We usually do these procedures under a MAC anesthesia. Oftentimes people can do this under just a local infiltration, but we prefer to use the MAC anesthesia. Local anesthesia is important for vasoconstriction and also for the prolonged analgesic effect. We'll inject xylocaine 1% with 1/100,000th adrenaline in the entire area over the maxilla, much like one would do if they were doing a Caldwell-Luck procedure. It also anesthetises the infraorbital nerve. We'll also inject in the temporal area where our cutaneous incision will be made and down along the lateral portion of the orbital rim to get hemostasis in this area. I then like to inject marcaine for the prolonged anesthetic effect. If we think of our anatomy, it's really pretty simple. What we're doing is we're dissecting down and elevating the periosteum over the frontal part of the maxilla, which is, as you can see, the anterior wall of the maxillary sinus. We know that our infraorbital nerve is located in the midpupillary line, as we can see here. So when we're dissecting, we'll use a blunt dissection technique to help protect any injury to this nerve and elevate up to the point where we identify the nerve. Okay. We'll elevate in a subperiosteal plane over the zygoma. We want to free up the attachments at the arcus marginalis, and also we know that the zygomaticus major and the zygomaticus minor attach to the periosteum and are confluent with the periosteum above the infraorbital foramen and along this orbital rim. So we want to elevate over in this area. We also know that the facial nerve in the midface area runs deep to the smas. We know that as it comes over the zygoma, it's above the periosteum. So if we elevate the periosteum, we know the nerve is above that and we can protect ourselves. And as we come down into this area, the deep layer of the temporalis fascia will split about 2 centimeters above the zygoma. It'll encompass a fat pad, and then it encompasses the periosteum. We know that above that deep temporal fascia layer is a layer of fibrofatty tissue, and above that is what Larrabee and other anatomists would call the temporal parietal fascia. And that's where the temporal branch of the facial nerve runs. So when we're dissecting, we'll dissect down and elevate over the superficial layer of the deep temporal fascia, elevating that fat pad down to the zygomatic arch in this area, and we know the nerve is above us. In this area, we're going to be in a subperiosteal plane, and then we'll want to connect these two, piercing essentially through the periosteum. We'll engage our implant in approximately this area, elevate, affixing to the deep temporal fascia in this area. One of the keys is we want to make sure that the implant does not ride above the zygoma or get above the orbital rim in this area because it could be palpated. We want to keep it mainly in this area and help to elevate these tissues, providing a nice contour. Let's look at the patient and our identification marks in this area. Again, our infraorbital nerve is in the mid-pupillary line. We've palpated the orbital rim and outlined where the zygoma would be in approximately this area here. We've looked and identified where our potential branch of the temporal facial nerve would be, 0.5 centimeter below the tragus, 1.5 centimeters above lateral brow, and draw our line. I like to course my incision between the ala and the lateral orbital area. I go approximately 2 to 3 centimeters behind the hairline, and I'll make my incision here approximately 2 to 3 centimeters. So I'll dissect down in this area and do it endoscopically, do this intraorally, and then connect those two areas, and then elevate the tissues in this area. We'll close this with just auto staples. We'll close intraorally with 5/0 plain suture. All to be smooth and it looks too jerky there. Okay, now let's do the